Welcome to the Compounding Center Connections, where we talk about different health conditions with our partnered practitioners. I'm your host, Jay Gill, a compounding pharmacist from the Compounding Center in Leesburg, Virginia. At the Compounding Center, we collaborate with practitioners, create custom medications to help our patients get better. So in this episode, our guest is Dr. Joseph Jemsek from the Jemsek Specialty Clinic in the heart of Washington, D.C. Today's discussion is on the use of Methylene Blue for Lyme Borreliosis Complex. By way of introductions, Dr. Joseph Jemsek is known to many of his patients by Dr. J. He is the founder of Jemsek Specialty Clinic and specializes in providing top quality care for those affected by Lyme and other tick-borne illnesses. Welcome to the show, Dr. Jemsek.
Thank you.
So could you please take a few minutes and introduce yourself to the listeners and the viewers and about your clinic?
Well, I've been in infectious diseases for 35, 40 years, more than that, actually. Started my career emphasizing HIV/AIDS, which picked up my second or third year as an internist infectious disease doctor and consultant, hospital consultant in Charlotte. I was also hospital epidemiologist during that time, involved with cardiac transplant work, which is those were the very early days. My interest grew to focus on HIV/AIDS. I diagnosed the first case of what came to be known as HIV in 1983, and the virus was discovered in 1985. So I think it's fair to say I focused the next 20 years on not only some general infectious diseases, but also HIV/AIDS. And during that time, there was a crossover with what I'm calling Lyme Borreliosis Complex. Others may just say Lyme Disease, which is proven to be a horrible illness. It's much more widespread than recognized. It affects all ages, genders and race groups, and it's devastating. It has a devastating predilection for involvement of the central nervous system, unlike any other pathogen that I'm aware, at least in a chronic state. So by chronic state, we can talk about months or years or decades. And so I became very interested in that, and quite by accident, really. But that's another story. At any rate, as my interest in HIV/AIDS continued, but that began to wane, I was being flooded by patients who heard that there was an infectious disease doctor who was willing to treat Lyme disease. So my education began, I'd say, around 2001, and we've just taken off from there. I find it to be a fascinating, unfulfilled area of medicine, in which there's a lot of crossover, in which it may facilitate the expression of other diseases by altering the immune state and causing the premature expression or just the expression of other chronic illnesses such as Crohn's disease or rheumatoid and that sort of thing. So there's association there. I'm not saying it causes those diseases. And so, yeah, we've been in DC for 12 years. And thoroughly enjoyed it. Recently moved to 2000 Pennsylvania in Suite 4000. And anybody that's done any moving knows what an ordeal that is. And we've survived it, sort of. But we're very pleased with our clinic and aesthetically and functionally. And I think we have a great staff now. We employ or have about 20 people, several providers, support staff in administration and nursing and so forth.
Well, the location is in a very central place and a beautiful office that you have. It's a great building that your practice is in.
Yeah, it's a food pub. I mean, it's a food hub for the GW students primarily. It's really something else.
Well, before we get started, a disclaimer that, everything to our listeners and viewers, that everything that we discuss today is just for informational purposes only, not for diagnosis or treatment. And Dr. Jemsek, do you want to add anything to it?
I would just say that first of all, I recognize and we appreciate the people that come to our clinic, and I recognize what sacrifices they make to come here because we're a destination practice, and we treat them accordingly with extended visits and, hopefully thorough treatment plans going forward, and we monitor them appropriately. And we monitor their safety labs if they're on therapies. And as Jay knows, I have used Methylene Blue for a few years now, but I want to emphasize to the listeners, whether you're my patient or not my patient, that I'm not proposing the general use of Methylene Blue for all conditions. I think it's a most interesting compound with a lot to learn about it. Its use in medicine has a fascinating history, but I want to make the disclaimer that I am not recommending that our patients independently, or anyone listening independently, go out and purchase Methylene Blue. And as Jay will indicate later, there's a difference in quality, and it's risky to do this without a doctor's supervision at any rate. I also realize how desperate some patients are and have difficulty accessing medical care. So there's a balance there, but I'm making the disclaimer that please don't assume that you're to go out and start Methylene Blue and that'll cure Lyme Borreliosis.
Thank you for sharing that, Dr. Jemsek. And this is one of the reasons we decided to do this podcast, was to put out credible information out there to the public. And thanks for sharing that. Now, ever since I've known you and worked with the practice, you've used Methylene Blue. Can you take a step back and talk to us about what is Methylene Blue, and how long have you been using it as part of your protocols?
I think we've been using it 3 to 5 years. I'm not sure. So when we make a change in a protocol, and we've been building our protocols for 2 decades, when we make a change, we introduce one concept at a time. And then we try to get some feedback. And in many cases, we don't have any objective markers, laboratory markers that help guide us, like we do with HIV, with hepatitis B, hepatitis C, et cetera, where we can measure the pathogen quantitatively. But I was intrigued by the fact that it could boost some activity, and there was, you wanted to know what the definition, so I'm just going to read a definition because
Sure.
It's a tongue twister a little bit, and I'll explain some of the terms. So it's a combination of heterocyclic. Heterocyclic means that there's a carbon chain that has something other than carbon in the chain. So, for example, there is a sulfa molecule in one of the carbon chains. There's 3 rings. It's electron accepting and donating, which makes it unique. In other words, it can donate electrons or reduce other molecules, or it can oxidize. And so I think that's an important distinction. It has a chloride ion, the sulfa ion, which helps it be soluble in water. And it's a unique chemical and physical, it has unique chemical and physical characteristics. And so it was first discovered as an industrial dye in 1879, so I'm told. And then in 1891, somehow or other, a couple of scientists, one was Paul Ehrlich, who's, I think, fairly famous name, thought it would have medical applications. Now, I don't know that story. That's an interesting story, I'm sure, how that came about. I should know it. But at any rate, it seemed to evolve very slowly as an anti-malarial agent. And then, of course, it has it's a primary drug of choice for methemoglobinemia, when hemoglobin is oxidized and needs electrons. Otherwise, the methemoglobinemia, which is usually caused by lidocaine, quite honestly, it's usually an in-hospital event where the patient turns blue and their oxygen carrying capacity is reduced because methemoglobin can't carry oxygen like hemoglobin. So Methylene Blue can reverse that fairly rapidly. There's certain protocols, and I've had a patient that's gone through that at Duke University, actually. And it's been used, as I said, it's not popular these days as a malaria agent, but it is became gaining popularity as a urinary antiseptic, along with methanamine in a product called Urabel. And more GU individuals are using methylene blue postoperatively to rinse the bladder and do things of that nature. So it's remarkably non-toxic if you use it in the right way. I feel like I'm forgetting a major indication.
Well, in preparation for this podcast, I looked up all the properties that it currently is listed, but it has, like you mentioned, antibacterial properties. It's got antioxidant properties. It has anti-inflammatory, anti-apoptotic, neuroprotective, and it provides mitochondrial support.
Yes, it does.
Yep. And having so many, it has so many uses or so many benefits. Is that what you saw 3 to 5 years ago or came across and decided to use it in your protocols? And are you seeing positive outcomes with it?
Yeah, so we cautiously approached it, and we looked into it, and we're always looking for any sort of therapeutic measure that will improve the efficacy of treatment and shorten the efficacy of treatment. So one day we'll have markers, and that'll help guide us as to, whether we can do what we're doing better and in a more efficient way. Our program is very successful, and obviously our patients are extraordinarily ill, many of them, and debilitated, and their lives are on hold.
Yeah.
And oftentimes they require a caregiver. I think everyone, certainly at your pharmacy, is aware of the severity of the illness. So I used it very cautiously, and one of the things that I learned early on, as I read the article by Roja, which is a 2011 NIH-based article, which is extraordinarily comprehensive, was that there's a difference between low dose and high dose. And, there's some vague references to what's a low dose and what's a high dose. And so with a high dose, I think you get more oxidative activities. Okay, so it becomes more of an antioxidant, because so it can steal electrons or donate electrons. No, steal electrons. And at low dose, my working assumption is that it is neuroregenerative. I mean, the rat model has shown that, and that's very exciting. So it helps with hippocampal enlargement. Hippocampus at the bottom of our brain is the source for our site for memory, both short and long term. The paraventricular areas are also enhanced, and there may be other areas of the brain that are enhanced. Now, all these studies are done in rats and or the test tube. And Dr. Zahn, who's a remarkable microbiologist at Hopkins, has done many studies in the past few years. And he did some in vitro work that showed that methylene blue at clinical doses could inhibit Bartonella very efficiently, and also the spirochete and the resting form of the spirochete, the persistent form. So that's very interesting. One other issue in the studies that came out was that it disrupts biofilm. And so we're being careful with that, because we have a methodology in which we do initial introduction of biofilm dispersing agents with sugar alcohols, in this case xylitol, along with lactoferrin, which helps bind heavy metals. And we don't want our patients having biofilm disbursement after first few days of treatment. So we melt and treat, and then we disperse, and then we treat what is released. And then we give our patient a rest. And this is something that we introduced several years ago, and it's made a huge difference, because if you don't address the biofilm, you're leaving the disease partially treated, and you're going to have relapses. But you can't do it continuously, and that's the trick. Melting biofilm continuously would create microbial chaos. And an immune system that's trying to rebuild or reboot or repopulate, that's not good because it can't handle it. And so I worry a little bit about methylene blue, although I don't think the way we use it is a problem, but we need to be aware of its activities. And we're looking at different approaches. So we would use a higher dose for treatment, and we'll get into what a high dose is. And then off treatment, as you may know, I have break weeks. It's a lot like chemo. We have weeks that are given for recovery and repair. And during those break weeks, we'll do low dose methylene blue. And then as patient goes further into therapy, there are more and more weeks available for methylene blue at a lower dose, with the idea that we think the literature tends to support that a low dose is more neuroregenerative, and therefore, that's what we want. Anytime we can find something that helps regenerate the brain, come on, we got to be all over it, right? If it's safe, and I think that's the exciting thing. And we have seen some definite results. I've had patients not infrequently say that was a game changer. That was a game changer for me. And we think it's very effective in combination with the other medications for Bartonella. If Artemisia is given as part of your program, one of the Artemisia derivatives or Artemisia itself, then using that in combination, methylene blue seems to have some activity against Babesia. That's enhancing. It's actually a better malaria drug than Babesia drug, which is interesting. So if you're going to use methylene blue for treatment, and you're still treating Babesia, and you want to intensify that treatment, it's with a higher dose and has to have an Artemisia product involved at the same time.
Wow. Great information you just shared. Now, the patients that you put methylene blue on, could you talk to us? Do they experience any side effects at the low doses or even at regular doses that you use in your protocol?
With the higher doses, I've had a couple of people who became a little bit disoriented, and I just think there's too much activity going on and too much too much shifting going on, too much dying going off in the CNS. But that's a minority of patients. And again, we don't use the high dose throughout the month. We're using the front part of our programs. With the low dose, I really, because a couple of people say I just don't like it, I can't handle it. Now, I think your audience needs to understand that methylene blue is very blue, and it will definitely change.
It's a dye.
It's a dye, so it's going to change your urine temporarily to blue, which stains the commode. So you need to learn about bartender's friend, which is like Comet, unless you don't mind a blue commode. But as far as side effects and intolerance, not a lot. I mean, we're always looking and always careful. Now, as you are aware, and I think one of your interested questions had to do with, okay, what's the contraindications or relative contraindications to methylene blue? Well, G6PD deficiency is definitely one, because methylene blue will prevent the conversion of NADP to NADPH, and that can cause hemolysis, all right, through its activities, and so it's contraindicated. So we screen our patients for G6PD before they're used. So that's an important criteria for physicians that may be listening in. And the other contraindication is use of SSRIs, having to do with serotonin reuptake. And the reason for that is that in the nucleoside pathway, in a methylation pathway, a neurotransmitter pathway, I should say, that ring, we have two terminal genes, MAOA and MAOB. And methylene blue is a much more potent inhibitor of MAOA than B. MAOA has everything to do with breaking down serotonin. And MAOB has everything with to do with breaking down dopamine. It goes to norepinephrine and then on through its cycle before it's finally degraded. So with MAOA, you can get a serotonin syndrome if you're not careful. So if somebody's on a high dose of a potent SSRI, that would be drugs like Prozac, Lexapro, Zoloft, Paxil, Celexa, or SNRI, which is Cymbalta and Effexor predominantly. Then you have to be careful.
Yeah.
So it's a relative risk. It's not, I mean, you may, at your group, decide that's a strict contraindication. I've taken the approach, and I haven't had problems, that if someone's on a low dose of sertraline or Zoloft, like 25 milligrams, I don't think that's an issue. You know, we're not, and we're going to be careful with the methylene blue. And so, because it is a relative contraindication. So if people are taking methylene blue and something like a low dose sertraline or Prozac 10 milligrams low dose, something like that, we just watch them, and we may cut our dose a little bit down and at the beginning, just to see that they tolerate it okay. And so far that has been fine. With drugs like Wellbutrin, which promote the retention of dopamine, it's less important because MAOB is not as impacted by methylene blue as MAOA.
Well, thank you for going over that and reviewing that. You know, we as pharmacists are cautious when we see that, and we always
that's your
collaborate
job
with the practitioners, but it's not an absolute contraindication, you know. So low doses, agree with you.
So when my employees fuss about a pharmacist, objecting to medication, I mean, some are overzealous and some a little bit territorial, which is a problem. But most of the pharmacists are just looking after the patient, and doing their job. And so I say, when I tell them, they're just doing their job. They and talk to them and explain what we're doing. For example, we may only dose a certain drug like rifabutin, 3 days a month, or maybe 5 days a month, and intermittently. And so it becomes, again, a relative contraindication or drug interaction. It's not like we're hammering daily with 2 drugs that are, one of which is going to create elevation of the companion drug by inhibition of the P450.
So talk to us then, how do you decide who's a good candidate and who should not be using it? How do you decide, with new patients that they might be a good candidate to start using or implement, methylene blue protocol?
Well, we don't use it at the beginning. Our program is very gentle introduction so that we can make adjustments in terms of clinical effects as we go along. So, if we do a very simple combination antimicrobial program 3 days a week, we'll do 2 weeks of that. There's no xylitol, there's no biofilm disbursement on the early programs. We will use Flagyl, however, at the end of the program, or tinidazole, and usually diflucan, but it's just an induction program.
Okay.
And so we seldom, if ever, use it at that point. But if you have a really sick patient and there's no contraindication, i.e. SSRIs, SNRIs, G6PD, then, or previous history of, intolerance of methylene blue, then we may consider it at some point in the next series of treatment cycles, and we'll add it in. And we're less hesitant to use it on the off weeks. Our patients are given 2 off weeks after they get through the induction program, so they have a couple of weeks there where they're just doing support meds for pain, sleep, whatever the case may be, for anxiety. But the threshold for introducing a lower dose is much less, as far as I'm concerned, before we get into treatment with a higher dose. So what's a low dose and what's a high dose, right?
Yeah.
Okay, in our world, and this is just, there's really no good information. I mean, so I read in one area, one paper that a low dose would be a milligram per kilogram, which I think is a little high. And a high dose is 4 milligrams per kilogram, which I think is pretty high.
Yeah.
So we're a little more conservative, and it's just a matter of being appropriately conservative, with our patient population is already sick and has already got all sorts of metabolic derangements, and God knows what else going on. So our low dose is something like 0.5, 0.6 milligrams per kilogram. So if we have a 70 kg person, that's a 35 to 40 or 50 milligram dose. And we dose it once. We do Monday through Friday. I don't know. That's just something I do. I like people to have a couple of days off. Yeah. So I do it Monday through Friday on the off weeks. Or if we're not treating and they're far along in the program, we'll use it in the on weeks as well, the treatment weeks. High dose would be something we're not comfortable using more than 2 milligrams per kilogram. So a 70 kg person, 150 pounds, would get 140 milligrams, possibly in divided doses. So 70 BID, although we've gone a little bit higher, but not much. So we're pretty conservative that way. As we get our experience accumulated as we go forward. But anyway, so the guidelines out there are very vague. So with the vague guidelines, I tend to be pretty conservative.
Makes sense. Well, to the listeners, I want to kind of take some time and explain to you how we at the Compounding Center compound our Methylene Blue capsules. And as you know, Methylene Blue is very readily absorbs. It can permeate through any membrane, even to through the blood-brain barrier, like you mentioned. So we emulsify the Methylene Blue in MCT oil, and therefore, increases absorption in the lymphatic system. And we are always using USP grade or pharmaceutical grade Methylene Blue in our products. And the reason we have to be cautious here is because, these USP grade chemicals come from with a certificate of analysis that tells us how many, what other contaminants such as heavy metals could be. So when somebody's buying this over the counter off online, be very careful, because you could be trading one problem for another, because it may be full of high heavy metals in much higher levels, and we've seen them all the way up to 11% in some cases. So be very cautious, because we definitely don't want to. We want to use the highest, quality chemicals, and working with a compounding pharmacy ensures that. So
I couldn't agree more, but I think the other term that's perhaps used is research grade, and you want USP grade. So if you go online and say, okay, I'm gonna try some now, and you go on Amazon, and just be careful what you're getting and what are your goals. And again, I am not encouraging folks to call us and ask for Methylene Blue, or to use this information as a way to initiate Methylene Blue in their programs until they talk to their physician. And both the patient and physician should be educated, because there are some risks, and it's an important tool, and like any tool, needs to be used appropriately.
Yeah, thank you for reiterating that, because that's probably the main reason, Dr. Jemsek. I'm so thankful for you doing this podcast with me, because you've used it, and I have a fair amount of experience with this for over 5 years, Methylene Blue. So we have a few minutes. Could you share a success story, perhaps, of a patient that using Methylene Blue?
Yes, I have a retired electrical engineer, or retired due to illness, who lives in Northern Virginia, and she's got better, but it's been a long process. I think she was on infusion years ago, and unfortunately, we tell people that their treatment's going to last 13 to 15 months, but sometimes because of various complications or intrinsic physiologic things that we don't quite understand yet, the treatment tends to go on. Of course, the sicker you are at the beginning, the longer it may take to get into regression, into a stable state. And she, for years, said, I just don't have my brain back. I just don't have my brain back. And, I was very frustrated. I put her on various neuroprotective nutraceuticals, and we do a lot of that. We kind of know we have our favorite frontline nutraceuticals that are neuroprotective predominantly. We make sure the patient's sleeping, make sure that the anxiety or their environment is supportive if possible. So we can't go to their place and do that, but we want to make sure that there's not a destabilizing element. Anyway, I said, okay, have you ever heard of Methylene Blue? And so I started putting her on, and she's a smaller lady, maybe 110, 115 pounds. And again, her native intelligence was off the charts, but she's lost that. And so I said, okay, let's just try this. And we use a low dose. We use it. She was on 1 week a month of maintenance. And I said, on the second, third, and fourth week, let's go Monday through Friday. And let's go, based on your body weight, let's do like 30 milligrams. And she came back 3 months later, 4 months later, and said, I think it helped, but I think I need a higher dose. And I said, okay, we'll do 40. So, because I'm still being very cautious. But, the next time she came in and said, that really helped. She said, that was a game changer. And this is in a backdrop of somebody who's been thoroughly treated and evaluated and was stubbornly failing to improve in CNS our cognitive abilities. And so, again, if you can find something that's neuroregenerative or neurostabilizing, it's gold. That's like a gold for our patient population. And so that's why we're so interested in various supplements that are neuroprotective, and they're all antioxidants basically. But we're trying to help our patient recover that brain, and that it's a long process. And there are certain other modalities that I'm okay with, which I don't need to get into, but only after the patient has been treated by our standards and we feel like the infection load is way down. Now we have this damaged landscape, including the central and peripheral nervous system, which needs every situation to benefit the recovery. And so I just talked about some of the basic life functions that have to be squared up. And now we have tried Methylene Blue, and we're pretty much going to be using it routinely in our patients that aren't getting cognitive recovery to the extent that we think they should.
Well, Dr. Jemsek, thank you very much for joining us today. You shared a lot of good information with us. How can someone reach out to your clinic?
So our number is 212-955-0003. We're happy to see new patients. We would like you to call and make an appointment with our scheduler. Her name is Linda, and she can give you a lot of information, and also check the websites and Facebook to get a feel for what we do and how we do it, and because there's lots of information there. We don't have all the answers, but we're learning rapidly. We've probably treated more patients than anyone in the country by history. I think we're at 16,000. And that's over 20 years. And that's just with all my partners and me working together. And so we've learned a great deal. And I'm proud to say we've made a couple dozen innovations in therapy, and that needs to continue. So what we do, and I feel strongly about this, what we do and other proficient physicians do in treating this illness should be its own medical specialty at some point. So especially for tick-borne illness, because there are protein manifestations, there's always multisystemic manifestations. And again, we have a disease process that is virtually unique in terms of causing chronic encephalopathy, which is a broad term for all kinds of cognitive issues in terms of memory, short and long term, mood issues, which can be major, of course, sleep issues, ability to understand and conceptualize a concept, things of that nature. So, that's what I would say about that.
Well, I'll make sure to put the contact information and your website information in the show notes. You have a wealth of videos on your website, very good resources for people to review.
Well, thank you. Well, we've done 23 or 24 live streams over the last 3 years, and they're each an hour. So that's 23 hours worth of information based on various topics and patient questions we do our best to answer. So we're going to continue doing that.
Great. So thank you, everyone, for tuning into the Compounding Center Connections podcast. We hope you found the information presented today to be helpful. If you have any comments or questions, please feel free to reach out to me at jay@compoundingcenter.com. Subscribe to our YouTube channel and our podcast channel, The Compounding Center Connections, and stay tuned for future episodes. Thank you, Dr. Jemsek.
Thank you for the opportunity, and keep up the good work.
Thank you.